Okay, this is about take 500 of my video for the anatomy bonus question, and I chose to do the sacrum. So just a couple of features first. From a side view, you can see that it comes forward and is at about a 45-degree angle. It doesn't come straight up and down, and its main attachments are to the ilium here. It's the coccyx here and L5 at the top of the sacrum, or the base. And this is the anterior view. Of course, we don't have a metal rod coming down. And you can see that there's foramina all the way down. So used to be like the vertebrae, so they used to be segments here that are now fused to form one plate-like structure like this. It's concave anterior, convex on the outside. This is the median crest, the bumps here. And again, these are the foramina where the nerve roots come out of. I should use a pointer. So this is S1, S2, S3, and S4 nerves. And as I indicated, we'll start with L5 here. This is the sacral horns on either side here. And there's a disc, a wedge-like disc in between the two. So there's a inferior articular surface of L5 that meets with the superior articular surface here of the horn, and this is considered the base of the sacrum, and it's important because we do a lot of assessment at this side. And I'm also going to explain the joints here, or the axes and the joints. So the joint here, you can see on this model, this would be a bigger surface. So this is where this attaches to the ilium, and that's called the auricular articular surface. Auricular meaning that it's shaped like an ear. And we're going to see later that there's 3 axes here that correspond with 3 axes on the ilium. And so there's the attachment that's called the sacroiliac or iliosacral, depending on which bone you're talking of moving. If you're talking about the ilium, it's iliosacral. If you're talking about the sacrum moving, it's sacroiliac. And I might as well just say now that the inferior axis here is talking about iliosacral movement, and the superior and middle axis are referring to sacroiliac movement. So, and now we'll just talk about some landmarks here. So, when we're doing some palpation, right here is the, I'll show you on the side here. This would be like posterior, it's hard to see and do this at the same time, posterior iliac spine. So the PSIS, that's where we landmark and we put our thumbs there, one on either side, when we're feeling first you do the greater trochanter here to see if they're in alignment on either side, to see if one is shorter than the other. Then you do the PSIS to see if that's in alignment, to rule out an anatomical short leg if they're both low on one side. Now for the PSIS, you use that in standing flexion test, and if you place your thumbs on either side and you feel one side is moving further than the other, then you know the dysfunction is on that side. That's a standing flexion. When you do a seated flexion, you want to move your thumb in more so that you just have contact with the sacrum, and that will rule out the hamstrings when you're doing the seated, because they can't, now they're out of the picture because they can't stretch, so they're not limiting the motion. So that's the standing and seated. So when we're doing palpation for sacral torsions and sacral flexions, you want to check, you go where the PSIS is, and then you go in and up, and that'll be the sacral sulcus right there. And what you're feeling for bilaterally is one side is going to feel like it's more shallow. You can feel more bone. One side will feel deeper. So the shallow side, say it's, well, I'm going to go with left because my thumb's on the left side, on this side, and then you would go, the second landmark would be the ILA, which is in this region here, which would be where the gluteal crease is. And you would, this landmark, you would feel which side bilaterally is more posterior. So if it would be this side again, if this was shallow and this was posterior, then the sacrum would have to be facing left. And that would be a left on left sacral torsion. However, I do have to talk about the axis first, so I'm just demonstrating the landmarks for now. And then the third landmark would be inferior ILA. So you're feeling which one is lower on either side here, and that pertains to a flex sacrum. So you'd be looking at, if you had not a shallow but a deep sulcus and an inferior ILA on the same side, that would be indicative of a flex sacrum on that side. And again, that relates to the axis here, because the middle axis is more anterior and lower than the superior axis, so obviously it's going to be more flexed or forward or deeper, and more inferior because, again, it's lower than the superior axis. I'll get into that a little bit later. The next part I want to talk about are the ligaments of the sacrum. So there's tons of them. There's like posterior, the short posterior sacroiliac, and the long posterior. So the short posterior is the oblique angle between the sacrum and ilium, and also, again, the long posterior is from the PSIS to the sacrum here, and there's also an anterior ligament, sacroiliac ligament, from the ala here to the ilium. And then there's the most important ones, like between the articulation of L5 and S and the sacrum, from the TP of L5, which is right there, to the ala, which is there. That prevents L5 from sliding forward on the sacrum. It's important to note as well that if that ligament is torn, it mimics SI pain. So it's really hard to tell if it's either the ligament or the joint, because they're so similar. It's pretty much impossible to tell which is injured. So that's the iliolumbar ligament. The next one is the sacrospinous. So here's the spine of the ilium, and it goes from the posterior lateral sacrum and coccyx, so all the way down here to the ischial spine here, and that restricts nutation or flexion of the sacrum, and that's important in respiration, because when a person inhales, the coccyx is going to extend, or the base will come backwards. I don't know how to illustrate that. The base, when you extend, will come backwards, and that's counternutation, and that happens when you take a breath. However, when you exhale, the sacrum will flex or nutate, which means the base will come forward like that. And that'll be important in a maneuver that we do for a treatment for a flexed sacrum. But that's just in regular breathing. It's on the middle axis of the sacrum that this occurs, and it's called counternutation or extension for inhalation, and flexion or nutation for on the middle axis for exhalation. Hope that was clear. And now my sacrum's starting to hurt because I'm sitting in an awkward position, but anyway. Okay. So that was the sacrospinous, and I said what that was for, and then one of the main ones again is called the sacrotuberous ligament, and it runs from the inferior sacrum and the coccyx here to the ischial tuberosity right here. So it runs like that. It's like you can feel it like a tube when you run your fingers over this part over the glutes, and it can sometimes restrict movement. But what its main job is to ligament limits posterior and superior motion of the sacrum because it runs like that. So it's going to prevent going up and backward of the sacrum and coccyx. And so those are the main ligaments. Now I can tell a little bit about muscles that are in the area. So right from here up is multifidi, and it runs bilaterally from the lower sacrum all the way up. And when that pulls, it's going to have a anterior and superior motion pulling it forward. And then piriformis runs from the GT of the femur and to the sacrum, and you can see the GT is both anterior and inferior to this part of the sacrum. So when that pulls the sacrum, it's going to pull it anterior and inferior. So the piriformis, that'll be important along with multifidi when I talk about sacral torsions. So a little bit about the axes now. There's 3 transverse axes that correspond on the sacrum, that correspond with 3 axes, almost like where the bolts are, but not quite, correspond with the ilium. And the middle one, as I mentioned before, is mainly associated with breathing. So it's associated with inhalation and exhalation. The inferior one is mainly concerned with iliosacral movement, which is the ilium moving on the sacrum, and the superior axis, the middle axis of the sacrum sometimes goes onto the superior axis of the ilium, and that occurs when let me just think for a second here. When there's a flexed sacrum, sometimes that's a normal motion of walking, I believe, but no, sorry, walking occurs on the oblique axis like that, and that would be a right axis. This would be a left axis. So walking occurs on the oblique angle like that. That's normal. But sometimes what happens in a sacral flexion is that the middle axis of the sacrum here becomes stuck on the superior axis of the ilium, and the side of the dysfunction is the side that's stuck superior, but the dysfunction is actually named for the side that comes back down to the middle axis. And so let's just go through what happens in a flexed sacrum. So it would happen when, like I mentioned, one side gets stuck on the superior side and the other side comes down to the middle axis of the ilium. So you're going to have one side, let's say it's the right side in this case, that comes back down to the middle axis. This side is stuck on the superior axis, and this side will be, since it's on the middle axis, will be more anterior here and inferior. So a couple things that'll be indicators. As I mentioned, when you're doing the palpation, this side will feel deep because it's flexed forward, and this will be more inferior because it's lower. It's a lower axis, and as a result, you would have an apparent short leg on the left side. This leg would feel longer if you're doing the test on the two legs in the prone position. That would be a verification for it. And so this would be a right flex sacrum. And it's odd because you don't treat the dysfunction, which is the left side. You treat the functional side, or the good side, because it's kind of like a window. This is a window, and it gets stuck kind of at a diagonal like this. This side's down, this side's up, and you don't treat that by pushing the side that's higher. You push the lower side to get them equal, and then it'll come back down on its own. So, and the way you would treat a sacral flexion is after you do all your extrinsics, treating piriformis, the glutes, all the structures in here, you would loosen the joint by having the person abduct their leg, and then you would apply pressure, an anterior superior pressure, when the person is inhaling. So you would watch their breathing and monitor, and then you would push it up like that. And then when they exhale, you would hold it, and then you would, when they inhale, you would press again until you reach a point where you